My name is Thibaut Hirsch, and I'm a proud member of the Youth Advisory Committee. Now, at last year's SNF Nostos conference, I had the opportunity to speak about my own past with mental health and the importance of increasing access to mental health resources for all. That is precisely the pressing issue that will be addressed in the following series of lightning talks by those who stand on the front lines in the global battle for mental health resource increasing. Our first two esteemed speakers are close partners of the SNF Global Health Initiative. Dr. Michelle Miller, who serves as Director of Mental Health Programs at the National Children's Alliance in the United States, and Dr. Inmaculada Insa Pineda, Child and Adolescent Psychiatrist at the Sant Joan de Déu Children's Hospital in Barcelona. They will be followed by distinguished guests who we are also honored to welcome. Dr. Olayinka Amigboden, Professor of Psychiatry and Provost of the College of Medicine at the University of Ibadan in Nigeria, and Dr. Shekhar Saxena, Professor of the Practice of Global Mental Health at Harvard University's T.H. Chan School of Public Health. Please join me in giving them a warm welcome.
I am honored to stand before you today and share information on responding to child abuse with a focus on helping children heal from their abusive experiences. Child abuse is common across countries. Most people are shocked to see that 1 billion children globally experience violence. In Greece, for school children ages 11, 13, and 16, 9.4% reported exposure to sexual violence. The number is likely higher due to limited data availability and underreporting. In the United States, in 2020, child abuse referrals were made on 7.1 million children, and there was an average of 5 child fatalities per day. Children are our most vulnerable population and our future. These statistics are unacceptable. National Children's Alliance is the membership and accrediting body for children's advocacy centers in the United States. Children, no matter where they live, should have access to the same high-quality services, and our accreditation standards work to ensure that. We have 950 CACs and 50 state chapters. Our CACs have trained nearly 1.6 million people in child abuse prevention. In 2022, our CACs served nearly 390,000 children. The CACs provide a multidisciplinary response to child abuse investigation and an opportunity for children to heal from their abusive experiences through evidence-based mental health services. In the United States, we too are significantly impacted by a mental health workforce shortage. We estimate that annually, 80,000 children who come through the doors of a CAC and need mental health treatment are not able to get it. To respond to this, NCA recently created the NCA Institute for Better Mental Health Outcomes to focus on training the workforce so that all children who need mental health services receive it. We are so thankful for our partnership and support from the Stavros Niarchos Foundation and our other funders. This map shows the locations of our children's advocacy centers. Most communities in the United States have access to a children's advocacy center. The dark blue infographic shows experience for a child when a CAC is not available. A child tells their story multiple times in places that can be scary, and families must find their own services, which, as you can imagine, is very difficult to do. The yellow shows multidisciplinary team members rallying around the child. Everything they need is in one place, and the professionals work together on a seamless response. Children's Advocacy Center multidisciplinary team members include trained child forensic interviewers, child welfare, law enforcement, prosecutors, medical, mental health, and victim advocacy. This graphic shows the type of cases CACs respond to. I'm sure you will not be surprised to see that 2/3 of all cases involve child sexual abuse, though services are provided for the other types of abuse as well. Over the last decade, we've focused on helping children thrive through a coordinated mental health response that provides the right treatment at the right time and in the right dose. We train CAC executive directors, victim advocates, and multidisciplinary team members on the mental health response. All members of the multidisciplinary team are involved in supporting the child and family through the process. The green boxes are functions primarily completed by child abuse professionals. The blue are mental health providers, and the orange is child abuse professionals and mental health providers. While every step in the mental health implementation roadmap is important, I will focus on the 4 steps outlined in red. You have access to this slide and can review all steps in the roadmap. Step 1 is screening. Screening children for mental health symptoms is critically important. Screenings are brief questionnaires that can be administered by non-mental health professionals, child welfare, victim advocates, medical professionals, school personnel. Screening results can be used to engage caregivers in the mental health referral. Approximately 30% of children seen at CACs reported suicidal thinking in the 2 weeks prior to their CAC visit. By identifying those children, CACs can assess safety, create safety plans, and triage based on urgent needs. Step 2, identifying and reducing barriers to treatment engagement is critical. Research shows that as few as 30% of children referred to mental health attend their first appointment, and many will drop out before completion of treatment. We can have effective treatments, but if we cannot get the child and caregiver to participate, they do not benefit. All multidisciplinary team members play an important role in exploring and helping caregivers overcome barriers. Step 4 is a quality evidence-based mental health assessment that uses both standardized measures, so questionnaires that identify symptoms, and a clinical interview with the child and caregiver. The results of the assessment are used to determine the need for and type of treatment and monitor symptom reduction throughout treatment. Information should be obtained from external sources to include child welfare, school, daycare, and other professionals working with the family. Step 7, based on symptoms, children are referred to a mental health provider with specialized training in evidence-based trauma treatment. A common symptom for children who have experienced trauma is to avoid thoughts and reminders of the traumatic event. Evidence-based treatments use gradual exposure throughout, and over the long term is more effective and less disruptive than avoidant behaviors. Non-offending caregivers are critical to child's healing. All evidence-based treatments that meet our accreditation standards involve caregivers. There is hope. Kids and caregivers can heal. I will give 2 examples of evidence-based treatments that are available at our children's advocacy centers. The first is trauma-focused cognitive behavioral therapy. We refer to it as TFCBT. It's delivered over 12 to 20 sessions and uses gradual exposure throughout. The core components include psychoeducation about abuse, parenting skills, managing emotions, challenging thinking, errors, coping skills, and the creation of a trauma narrative that reduces trauma symptoms through desensitization. The second is child and family traumatic stress intervention, which is an acute intervention that's delivered in the 30 to 45 days after the traumatic event or disclosure of the event, and is delivered in 5 to 8 sessions. There is strong research evidence that shows that it can interrupt the development of post-traumatic stress disorder. It strengthens communication between the child and caregiver to enhance emotional support and teaches coping skills. By caregivers participating in their child's therapy, their post-traumatic stress symptoms reduce as well. As we know, healthier caregivers help children thrive after an abusive experience. So this is a quote from an 11-year-old. It helped me get rid of that sick feeling I had. And so I want to end with the good news, and that is there are short-term, evidence-based treatments that work and help children have brighter futures. Thank you.
Kalimera, I'm honored for being here. My talk is about a companion, a novel multimodal intervention plan. First of all, I would like to explain that this program depends on Sant Joan de Déu Hospital. It's a children and maternity hospital located in Barcelona. It's one of the main pediatric hospitals in Europe. It's private, non-profit institution, and it's subsidized by public health system. Humanization and hospitality are our core values, and all facilities are designed to make the patient and family experience more comfortable. And what about our child and adolescent mental health department? In the next slide, you will see some numbers about the visits made, the number of professionals, the number of devices, but I would like to highlight that we attend the 20% of population in Catalonia. The mental health care offered in our hospital accompanies the patient in all stages, from prevention to the end of the specialized treatment. And now it starts with the program Acompanya'm. This program is a residential, educational, and therapeutic unit for children and youth patients with a severe mental disorder and also with a high social and family complexity. We have a capacity for 28 beds. 6 of these beds are for children under 12. And the ratio patient professionals is 1:3. This unit is designed by educational coexistent therapy apartments, in which that means we have a common areas in where we work social skills. The target, our patients, has high complexity, high risk of social exclusion, and from families at risk of claudication. But what does it mean, claudication? It's the loss of the abilities, the family disabilities, to attend in an adequate way the needs of the patients. And sometimes that means, or that develop into a withdrawal or custody. For an example, high complexity, what does it mean? 84% of our patients have more than 3 diagnoses in mental disorders. 20% have intellectual disability. 30% have suffered sexual abuse. And all of them have serious behavioral disorders. Our method, we work through comprehensive and integrated intervention based on functional recovery and with a reconnection to the community. And this is done by a multidisciplinary approach. We have psychiatrists, psychologists, workers, social workers, educational workers, teachers. This, you can see in this slide, some of the activities we have in our unit. But when the patients are prepared, when they have enough autonomy, we also search for them activities outside the center. We look for them the suitable school. We look for them activities, sportive activities, language classes, drawing classes, wherever they motivate. About activity, we have more or less 35% discharges per year. The average stage is around 11 months. And now we have already treated more than 100 patients. In results, in all cases in which the family had the guardianship of the patients, family claudications has been avoided. There is 26% discharges of those patients under guardianship that have returned to their original homes. And 100% of the cases, or maybe, let's see, 100% of the students have been linked to an educational center adapted to their needs or to a training project. Let me finally, I would like to explain a case, John's case. John was physically abused by his parents during childhood. Unfortunately, his parents suffered from different addictions. At the age of 6, John was under guardianship and was sent to a residential device. At the pre-adolescence, John turned from a victim to an abuser to his classmates. He just went to school 2 hours per day. Also, at this time, depressive symptoms and autolytic thoughts began. And those are the reasons why he entered in our program. After 1 year of intensive and multidisciplinary treatment, John could return to his grandmother's home, and he was rejoined to another secondary school. For John, it wasn't just a recovery. For him, it was a rebuild of a project of life. And as you should know, new projects represent new challenges. This couldn't be possible without the support of my mental health service and also the hospital manager, Manela Castillo. I feel really proud of being here and Afghanistan to establish Niarchos Foundation. Thanks.
I'm deeply grateful to the organizers for inviting me to come and speak about capacity building strategies effectively employed for child and adolescent mental health in sub-Saharan Africa. I tell you this morning a story, a child and adolescent mental health story of why we did it, how we did it, and what were the results. Why did we have to build capacity for child and adolescent mental health in sub-Saharan Africa? Just over a decade ago, there was virtually nothing in existence, very few services, very few trained professionals. And in addition to that, poverty, people living in slums and in very difficult situations. Even up to now, we find that in most sub-Saharan African countries, between 70%, 60% live on less than $1.9 a day. You can see the deep areas. And of course, there's a recurring cycle, a vicious cycle of poverty, lack of education, hunger, low income, lack of potential and opportunity. And of course, the consequence is poor health, physical, mental, and social health. We also have large populations of out-of-school children. You can see Sub-Saharan Africa, primary school, millions of children out of school. And of course, we know school is a very important mentally healthy environment. There's a focus on child mortality, high rates of malaria, HIV/AIDS, diarrheal diseases take away the focus from mental health. And of course, there's a neglect. Mental health and physical health are separated, and it should not be that. In addition, the burden increases because we have children in especially difficult circumstances. Street children, walking children, children in institutions, and you can see this, a juvenile justice institution, lots of children with mental health conditions, children in chains and in pain, children seen to be demon-possessed or witches. Even when mothers come many times with depression, we have higher rates of depression in the Sub-Saharan Africa. The depression doesn't manifest as depressed mood or loss of interest, but in their children as frequent malaria, neurodevelopmental concerns. 1 in 5 would have a mental health condition. And of course, 50% of adult psychiatric illness starts before the age of 14. What was the state of calm about over a decade ago? Few CAMP services, shortage, lack of training opportunities, no mental health in child health services. So that was why we embarked on this capacity building story. And that's the story I tell you. How did we do it? We felt we needed to have an 18-month training Masters of Science program in the College of Medicine, University of Ibadan. And what were the 5 ingredients we needed for this? The first important, funding. We're so grateful to the MacArthur Foundation for providing us with the seed money that we started off with. Funding is key to so many things. We also needed services and facilities to train. Fortunately, I had been involved in developing services. I initiated the first mental health clinic for children and adolescents in my hospital and built this up through training. It expanded. We also needed trainers. There were virtually no trainers on the African continent in Sub-Saharan Africa. So we built partnerships on the International Association for Child and Adolescent Psychiatrists, and all through collaborations with Harvard Medical School, Imperial College, and particularly I must emphasize that we had Africans in the diaspora who came to help us in the initial period. And as we built local capacity, they were less able to come. We did not need them so much anymore. Trainees also. We needed scholarships, which we got from the funding. We used networks to attract trainees into our program. And of course, curriculum was very, very key. And I give you 5 ingredients, 5 essential aspects of the curriculum. First of all, practical clinical sessions to change attitudes were very, very important. Collaborative methods with parents. Leadership was very important because these were pioneers going back to their countries. Multi-professional training. It was not limited to psychiatrists or psychologists, but we brought in different people. And of course, research was very, very important. You build research, and that leads to policy. And then we use free online resources, the IACAPAP textbook and the MHGAP, a WHO package. And then I give you very quickly 10 outcomes of this capacity building story. The first is that we had, in just 10 years, 124 trained, and of course, more females than males. These are the sets we turned out year by year. Year by year, we were turning out, and then from 14 sub-Saharan African countries, we were able to train. Cameroon, Eritrea, Nigeria, Ghana, Liberia, Sierra Leone, Rwanda, and so we were building up capacity for mental health, child and adolescent mental health on the African continent. That's the advocacy has started in all these countries, and our graduates have pioneered services all over the African continent. Multidisciplinary training, sustainability. Those who are running the program now are graduates of the program. Research, we've been able to produce 23 peer-reviewed publications, and these are still ongoing. And then attitudes have changed. Many of those who came now know that mental disorders are manageable very effectively. NGOs are formed across the African continent. And then the 10th component is leadership. Many of our graduates are now leaders. We have Simbogani Kayola, country director for Massicors. We have a leadership here from Cameroon, a youth commissioner in Lancet Commission for Child and Adolescent Wellbeing. And then the African Association for Child and Adolescent Mental Health is led entirely by our graduates, the president, vice president, the secretary, leading child and adolescent mental health services, facilities, advocacy, policy on the African continent. That's the precedent. And with that, I end my story of why, how, and what with regards to capacity building for child and adolescent mental health in sub-Saharan Africa. I thank you for listening.
Ladies and gentlemen, and also the young people in the audience who are going to make the maximum difference, I come here to present a global public health perspective on child and adolescent mental health, which includes policy as well as services. I'll focus on three aspects: determinants, data, and decisions. Having worked for WHO for more than 20 years, I will begin with a slide that depicts the WHO's definition of health, a state of complete physical, mental, and social well-being. And all the three aspects are related to each other. We realize it every day. If we are physically unwell, we cannot be mentally well, and even socially well, and vice versa. The COVID pandemic demonstrated it very well, or rather very badly, that a physical condition gave rise to so much problem in our mental health and in our social well-being. And this applies to adults, but this applies even more so for children. Mental health has been defined by WHO as a state of mental well-being that enables people to cope with the stresses of life, to realize their abilities, to learn well, to work well, and to contribute to their communities. What could be a better definition for children's development and mental health than this, to contribute eventually to their communities? The children of this world cannot be divided into two groups: those who are mentally normal and those having a mental disorder. It's just not as simple as that. This is the traditional clinical perspective. You wait for children to have a disorder and you identify and treat them. This is not the public health perspective. Public health perspective is taking mental health as a dimension. There are children who are developing normally. They have normal mental health, so-called normal mental health. You can still promote their mental health by giving them an environment that is mentally healthy. Some children will have developmental delays and disorders and mental distress. You can prevent them developing a mental disorder. Of course, some children have a mental disorder or a developmental disorder. You can treat them, you can achieve a remission, and if there is a disability, you can strive towards a full recovery. Mental health of children is affected by a large number of social and economic determinants. In fact, my task has been made so much easier by the earlier speakers demonstrating various kinds of determinants, and also in the earlier session by the representatives of WHO and UNICEF. These are public health aspects that need to be kept in mind. Extreme poverty, one of the major determinants of mental health, in children, adolescents, and in adults. And not only in poor countries, not only in a country like Nigeria, which you heard so much about, but in all countries. In fact, poor people in rich countries have a very high vulnerability for mental health, and there are poor people in all rich countries. Similar issues about abuse, violence, substance use, homelessness, and lack of education. Still, hundreds of millions of children do not receive the education that they are entitled for, and many, many others. Policies to improve the social and economic environment can have a large impact. In fact, that perhaps is the intervention that can have the largest effectiveness for promoting mental health of children, preventing disorders, and these interventions are extremely cost-effective. Of course, children who have a disorder need treatment, nobody doubts that, but resources need to also go into promoting the environment in which children live, and here I'm talking about all children. We need accurate and timely data to implement what I'm suggesting. Population level data is critical to developing policies, and data needs to come from a variety of sources and not only from the health sector. Population level data can help us to identify children at high risk. The potential of big data and artificial intelligence is something which could be very great, is still not being realized fully, but it has the potential to be a major game changer in providing the environment which children need to develop healthy mental health. We are involved in an initiative which is called the Countdown Global Mental Health 2030. You can read more on the website, which accumulates data and presents it for the entire world, for all countries, on a variety of determinants. In this map, I present the mean years of schooling. Imagine that this kind of global map could be converted into local maps about each country, about each community, about each neighborhood. And that's what will give us the kind of data that can make into better policies for all the children who are living in that neighborhood or in that country. Children's mental health should be a whole of the government responsibility rather than only of the Ministry of Health. I hope there are some people in the audience who are responsible for other sectors, and that's where their contribution can become so critical. Mental health of children is too big and too important an issue to be left to the Ministry of Health. Children's mental health is the most critical asset of all societies and countries. Let's protect and promote it by data-driven population-level policies. Thank you very much.